Hello, and thank you for joining me today. My name is Stephanie Saba, and I'm proud to serve as our lead radiology technologist and flow coordinator within Michigan Medicine, Outpatient Radiology Department. I oversee operations at the Northville Health Center, Livonia Center for Specialty Care, Canton Health Center, and also the Burlington Building. Today, I'm excited to talk to you about a topic that impacts not only our workflows, but also our patient satisfaction and health outcomes, optimizing patient flow in outpatient radiology. When we talk about patient flow, we're really talking about the patient experience and how effectively and efficiently they move through our health system from check-in to check-out, and how we as professionals make the journey seamless. I'll be drawing in on our collective experience across our multiple sites and the unique challenges and successes we've had to share lessons and strategies that I hope resonates with you. Let's start with why optimizing flow is so important. In outpatient radiology, delays and inefficiencies don't just cause frustration. They can delay diagnosis, treatment, and ultimately impact patient care. According to a 2022 article that I read, Journal of the American College of Radiology, inefficient patient flow contributes significantly to missed imaging appointments, longer wait times, and even poorer outcomes, especially in high volume outpatient settings. But beyond the clinical implications, there's the patient perspective. Think of a patient who arrives anxiously for an epidural injection for chronic back pain. If they're left waiting 45 minutes past their appointment time, that anxiety turns into dissatisfaction. In an age where patients have choices and where experience often guides those choices, we cannot afford to ignore the impact of flow. At Michigan Medicine, and particularly the outpatient world, where we see a high volume of patients in a fast-paced environment, optimizing flow has become not just a goal, but a necessity. Managing patient flow across a single site is challenging. Doing it across multiple outpatient centers with different layouts, staffing models, and patient populations adds complexity. At Northville, for example, we juggle multiple MPU procedures like radiofrequency ablations, medial branch blocks, SI joint injections, all while maintaining flow in our general outpatient imaging in a very busy ortho clinic. Meanwhile, at Livonia, we serve high volume DEXA scans that often bring clusters of walk-in or add-on patients. And Canton faces challenges in routine outpatient radiology, and Burlington is a mix of schedule MPU procedures. Each site has a different rhythm, and yet we are all expected to maintain consistency in wait times, service quality, and patient satisfaction. One challenge we've encountered is resource imbalance. Technologist staffing might be sufficient at one site, but strained at another. Likewise, clerical staff may face different registration systems or patient volumes. Without coordinating and communication, this can lead to bottleneck and burnouts. So what we learned from operating across the multiple site system, number one, I would say this standardizing best patients across sites. We've worked to standardize key workflows across sites. For example, how we prep patients for arthrograms or injections. This ensures that no matter which site a patient visits, they experience consistent communication, safety protocols, and scheduling accuracy. It also helps with technologist and clerical float staff between sites. They know what to expect. Cross-training is a huge one. Cross-training has been a game changer. By empowering technologists and clerical staff to take on hybrid or flexible roles when needed, we've reduced downtime. For instance, a clerical staff trained in imaging prep can assist during a surge period, and techs trained in multiple modalities can switch between procedures like ultrasound injections and DEXAs based on the demand. Improved communication systems is another one. We've implemented shared calendars and centralized patient tracking systems that alert teams in real time when a delay occurs. For example, if an injection is running late at Northville, our clerical team can proactively notify waiting patients and reschedule others as needed. This reduces the frustration and gives patients the sense of their time is respected. Also utilizing a lean and time motion studies. At Canton, we used a lean based time motion study to understand the bottlenecks in ultrasound scheduling. By identifying repeat slow points, like waiting on a radiologist approval, we adjusted the scheduling templates to better reflect the turnaround times. And as a result, we had a 12% increase in daily throughout without reducing time per patient. And then another one, we also pre-visit communication and scheduling optimization. We also focused on the front end improvements, confirming prep instructions ahead of time, streamlining insurance verifications, and staggering appointment start times for complex CT procedures have reduced the check-in congestion. In Livonia, for example, we separated DEXA's add-ons and dedicated blocks, which helped the team better anticipate patient flow. At Canton, like I discussed earlier, we used a lean-based time motion study to understand bottleneck in ultrasound scheduling. By identifying repeat slow points, like waiting on a radiologist approvals, we adjusted the scheduling template to better reflect the turnaround times, and the result was 12% increase in daily throughout without reducing time per patient. At the Northville Health Center, we held a weekly 10-minute flow huddle where clerical and technologists would quickly flag issues and successes. One small change, adding a color-coded patient board, came directly from a technologist's idea, and it's now at multiple sites. As you can see, technology plays a huge role in optimizing flow. Real-time dashboards showing room utilization, patient status, and staff availability have helped us make smarter, quicker decisions. We're also using the data more effectively. For instance, we noticed through data analysis that Monday mornings at Burlington had a 20% higher no-show rate than other times. With that knowledge, we now slightly overbook or call patients the day before for reminders, reducing time waste. But let me be clear, data alone doesn't fix problems. It must be paired with a culture of responsiveness and staff engagement. It's about using data and not to punish, but to empower. None of these improvements are possible without the buy-in from the teams and doing the work. As a lead, I found that involving staff in identifying flow problems and inviting them to co-create solutions yields the best results. Like I said earlier, at Northville, we held 10-minute flow huddles where the clerical and technologist teams would quickly flag issues and successes. And then one of the small changes, the coding a patient board came directly from a technologist idea. And empowering your team to care about flow gives them ownership. And with ownership comes pride, innovation, and accountability. Optimizing patient flow in outpatient radiology is not a one-time project. It's an ongoing commitment and it requires alignment across clinical, clerical, and leadership levels. It demands them to adapt across different sites with unique pressures. But most of all, it asks us to keep the patient at the center of every decision we make. As someone who oversees multiple sites, I've seen firsthand that even small changes can yield big results when implementing through thoughtfully and collaboratively. Whether it's standardizing processes, embracing data, or building a strong team culture, we can and must keep refining how we move patients through our systems. Let's continue to share our lessons, learn from one another, and remember that improving patient flow is ultimately about improving patient care. And I just want to say thank you all for taking the time to listen to this presentation. And I hope you have some insight on how to lead a successful team within radiology. Take care.